All right, I should have coordinated just a little bit better, but I'll actually go through a couple of slides pretty fast because Ed just touched on them. But I'll briefly recap the CMS role. That's really why for most of the non-hospital entities this is important. Touch on some key things that are important for emergency management programs, specifically speaking in this session to the emergency plan. But some of the topics that we're going to talk about in the next meeting and the future meetings are really part of that emergency management program. Talking about coordination with community partners. This is a part of that. You know, make note of that, document that with the attendance sheet and things like that, and then briefly touch on some training and exercise. So Ed touched on that. The one thing I'll comment here is really just a recognition of what drove this. And it was a lot of hospitals, but even more importantly, some of those non-hospital entities that were not regulated by either the Joint Commission or DNV and some of the other agencies out there. In the big events that we've had throughout our community, that it's really set the healthcare facilities on their heels. And so that's really what drove this process. It was a fairly lengthy process, went through a couple of years of feedback, and then as Ed stated, it was came into play last year. So for those of us in hospitals, and you'll see this language in the CMS guideline, they talk about COPs or conditions of participation. Number of different areas. The one that we're going to focus on today specifically is the planning, which, as I said, is really part of the emergency management program, which is everything really, you know, maybe minus the fuel and generators, although that's a part of it in that upper left block. So the plan, we're going to talk about that it really should be a risk-based plan. So those that, how many attended, was our meeting in January last time? How many attended the January meeting? So I touched briefly on a high level of hazard vulnerability assessment. Dean dove really deeply and nicely into the HVA process that they did at Deaconess, and so that really informs your emergency plan. But then there's some other things we're going to talk next week about, or next time, about policies and procedures, communication plan, and the language in the CMS rule talks about training and testing. It's really training and exercise, same thing. So I like this picture that I stole from I forget who, but with technology, it's a wonderful thing. You can cut and paste things, but it's kind of that preparedness umbrella. But the description about a program versus a plan, the program is really that overarching pieces, whereas the plan or the program include plans and policies and procedures, communication, and that training and testing or training and exercise. And the piece out of the bottom is really right out of the CMS rule where it says we expect a facility, so that's the 17 suppliers and providers, to have a comprehensive emergency preparedness program to address all the required elements. And as Ed touched on, I'll show you some of the same resources and maybe some others to complement it. There are a number of different templates that are out there that you can take a look at. Please do that. And the other thing I'd encourage is, you know, talk to our community partners. And similarly for me, you know, from a hospital standpoint, it's important for me to talk to, especially those hospital or the non-hospital partners that maybe we haven't worked as closely with in the past, that we really do need to establish stronger relationships. So emergency management really encompasses 4 or 5 phases depending on how you look at it. It's mitigation, prevention, preparedness, response, and recovery. And really at any given time, you could be doing all 4 of these different phases of emergency management. Even in response, you know, you're going to start your recovery. And even in response, you're probably going to be taking some mitigation actions and talking about preparedness. So it's really something that's constantly, you know, it's kind of often you'll see it in a circular fashion as the picture on the right shows. And then unfortunately, you know, the blessing and the curse of emergency management is there's no standard out there. So the cool thing is you can do whatever you want. The curse of that is, as we try to work together, each of us does things differently, and there's no one set standard to turn to, and so it does pose some challenges. So again, emergency management, very relational. It's very important that we understand what each other is doing. So diving a bit deeper into the emergency management program and specifically the plan, in most cases, most people will refer to it as a framework. It's not especially prescriptive. Policies can get more prescriptive, but our program and our plan is really that framework to guide our process. Part of that is because we recognize that in every response and disaster, what's the one thing that we usually don't look at? The plan. Yeah. So it's important that we train our staff and our people to be able to adapt to the situation that they're in. Now, I certainly would advocate using your plan and developing checklists, but it's also just as important that we've got a strong foundation and good experience and good partnerships to reach out to at time of event. So some other things that you want to think about is the regulatory requirements. So the new one for most of the 17 suppliers and providers is the CMS Role. For those of us in hospitals, whether it's our critical access hospitals or our larger hospitals, we are typically regulated by either Joint Commission or DNV, or there's one third one that I draw a blank on. And then some of the really small hospitals aren't regulated by one of those agencies, but you really do need to understand your regulatory requirements, policies and procedures maybe of your company and your organization. Chris talked a lot about the VA. There's certainly some overarching ones for the VA. Many of us are part of larger systems, and so there's some policies and procedures that we have to comply with there. And all of those really are part of your emergency management program and should be integrated into your emergency plans. We talked that it should be all hazard. I'll speak to this a little bit more. Again, think back about the presentation in January and the hazard vulnerability assessment. You really can't prepare for every single threat and hazard that's out there, and there's probably too many to do in one year. And so the purpose of that annual review of the HVA, our hazard vulnerability analysis, is to base our planning for that year, our training and our exercise program on those priorities that we established through that process. And that should be a collaborative process. So that was the intent of the presentation in January, was to show you that regional perspective, to show you a deep dive into the example that Dean gave us from Deaconess, and allow you to use those to inform each of your own particular processes. It should cover staff roles and responsibilities. In Joint Commission, there's certainly a number of specifics that we have to cover. It should be sustainable. We had a meeting before this one about our Disaster Medical Coordination Center plan, and we often think about, well, during the day when we've got a lot of extra resources, we have all these people coming, but the reality is most of the things that happen are in the middle of the night when we're much less staffed, and so we have to build our plans around that. And then, the importance of exercising. Bruce's presentation on Whitman County's exercise was amazing for such a small community to pull that together. But you'll learn every single time, even if it's a really small exercise where we just pick up the phone and try to call the number, as wasn't done between Pullman and Whitman County Hospital, and you realize, geez, that phone number isn't the same number it was 10 years ago when I called it, or last week when I called it. So I definitely encourage you to do exercises. And take advantage of what happen at time of event, whether it's the little thing that your staff meeting, unfortunately, or hopefully that's happened, outside of our community and someday here, and talk about, what do we need to do, and what's this run, hide, fight, and what sort of policies and procedures do we need to do to make our staff and our patients better prepared. So real quickly, to reference back to the HVA last month, this is kind of a pictorial that I use in a lot of my Providence and St. Luke's meetings that kind of shows the disaster du jour in this area. Certainly it's not every disaster and hazard that's out there, But if you weren't in that January meeting, look back at that material there. And then a couple last slides on the emergency operation plan. It really does need to be focused on the facility. It needs to be informed by the community that we live in and the resources that we have available to us, and prioritize those threats and risks. And again, you won't be wrong if your multi-year plan doesn't have you doing an exercise or a drill on every single hazard. But over time, you should hit those hazards that you've prioritized in your HVA, and that's really the intent of that. It's an annual process. You really have to show that annually. You need to put that in front of leadership. Just about every group that sees that is going to be have a different take on it. And all of them are important to inform the process. You need to take a close look at the population that you serve, and whether that's age, whether it's what the languages that are spoken, their mobility or lack of mobility, and all those types of things, and then really collaborate with your partners, because in the really big events, it's important that we're aware of each other's plans and how to get in touch with each other and work collaboratively together. A couple of other things we didn't talk about, but you do see in the CMS rule is a reference to continuity of operations. There was a really nice workshop that Coeur d'Alene Panhandle Health and Idaho sponsored a couple of weeks ago. I don't know if many were able to make it to it, but there's some great resources for templates around continuity of operation, and certainly that new CMS rule talks about the importance of that. And succession plans. So, as I often joke in my facility, I'm a single point of failure. I'm the only person that does emergency management, and so it's really important that we have some succession planning in our processes and those training and exercise, 2 and 3 and 4 deep as much as possible. So last slide on resources. I think Ed referenced several of these. I guess I'd highlight a couple that came that I've looked at that I think really has got some great information. California Hospital really has been very progressive, and they've got some great templates on their site. Recently was made aware of some resources on the LA County Health Services EMS agency site, especially around COOP. They literally have COOP plans by department and modality that is pretty incredible, and they literally are just templates that you can take and apply in Word documents. And so look at those resources are out there. At the federal level, there is a document that talks about emergency operation plans, and that's CPG 101 that I've got referenced there. And then I think Ed is our only emergency manager here locally, but there might be some on the phone. But do reach out to your local emergency management partners. Get their what they call HIVA, or you'll hear the term THIRA, Threat and Hazard Identification and Risk Assessment, and understand with your community partners. And again, that should inform your HVAs that we do locally. So I think, last slide is this, just kind of that umbrella preparedness program and a reference in the CMS language about integrated healthcare systems. So what this means to me is St. Joseph's Care Center, which is on kind of the campus of Sacred Heart, I'm pulling them into kind of my integrated healthcare system plan, and then having some annexes that will help them. So if you have that opportunity, if you're part of a system, that is something that they talk about in the new CMS role, and I think is a good approach. So we're not recreating an entire planning process for an organization that's really part of a bigger system group. All right, any questions about that before we break into our work groups? So again, this is kind of a journey. We touched on HVA last time. This was the planning part, communications next time, and then training and exercise, I believe, in the last session. Our policies and procedures, and then communication. So, all right, thank you.
So just a notice for those of you on GoTo, we do not have the capability to apply GoTo to the work group breakout sessions. So GoTo will be disconnected at this point. Thank you very much for participating in our discussions today. And please provide any feedback that you might have to the HCC email with any feedback that you might feel would make the meetings better.